evening, everyone. This is Mohammed Bitar, a rheumatologist at Oregon Health and Science University. I'll be co-moderating this symposium with my friend and colleague, Dr. Soha Abadi. It is a great pleasure to welcome you again this year to our joint symposium brought to you by leading international spondyloarthritis organizations, Spondyloarthritis Research and Treatment Network, SPARTAN, Group for Research and Assessment of Psoriasis and Psoriatic Arthritis, GRAPPA, and the Assessment of Spondyloarthritis International Society, ASAS. A lot of exciting research has been done over the past year, and our experts will be discussing high-yield topics to keep you up to date. After each talk, we will have a 5-minute Q&A session. Please use the microphones that are available in the room to ask your questions. This symposium will be recorded, so it will be available for viewing on demand in the future. And now we move to our first scientific session, which is Axial Spondyloarthritis Year in Review. It's given by Dr. Fabian Proft, who's a rheumatologist and senior researcher working at the Charité University Hospital Berlin in Germany. He received his medical degree at Munich University, where he also specialized in rheumatology. His main research topics are axSpA and psoriatic arthritis, with a strong focus on randomized controlled trials, digitalization, outcome measures, and imaging. He published numerous research articles, reviews, and book chapters focusing on spondyloarthritis. He is an active member of GRAPPA and ASAS and Immunet. He currently is the chair of Young GRAPPA and was the ex-Young ASAS leader. Dr. Proft will be speaking to us about Axial Spondyloarthritis Year in Review.
So, very good evening, everyone. And thank you so much for the invitation. It's an honor for me to be here, and it was such a pleasure to prepare the presentation because this really made me go through a lot of literature, and I enjoyed it. And now I'm a bit anxious because I see a lot of the authors that will be highlighted here in the audience, so please be kind in the question and answer afterwards if I do any mistakes. This 1 year in review, Axial Spondyloarthritis. And here are my disclosures. Just to quickly get you on board, I will make the concept of spondyloarthritis. And I was focusing on axial spondyloarthritis, but in my search terminology on PubMed, I was also including ankylosing spondylitis to make sure not to miss any relevant articles for the presentation today. In the third search methodology, 879 clicks or interested articles were found, and I was just screening them, and it was hard to make a selection. So if you are an author that published something very interesting in the last year and are not presented today, please don't blame me. It was hard to make a cut to make the time. And so I ended up with 12 articles, and I focused on original articles, and I pre-specified that I would only include full-text manuscripts. But I changed this in the end because I thought that there's one study that was presented as an oral presentation at EULA and ACR that I also want to share, and because I think this has high implications for us. And here, this is going beyond what I was going presented today because I was trying to make some clusters of what research is highlighted and published in the last 12 months. And you can see here just some words that were coming out quite often, and I think they are relevant, they are all familiar for us, but gives us a quite good indication of what are the research focuses and the hot topics currently going on in axial spondyloarthritis. And so I was trying to cluster them a little bit more and put them into buckets, and I start with diagnostics and clinical topics, then I will speak about treatment withdrawal, highlight international management recommendations, and then speak shortly also about new modes of actions, new treatments available, and yeah, exciting stuff to come. First, on clinical topics, I was intrigued to also here show the ASAS consensus definition of early axial spondyloarthritis. And I think this makes sense because how early is early? This was the question of this SAGE. I have a problem here, but this should not affect this. And so there was a task force. It was a very elaborated process, systematic literature review, discussion rounds, lots of discussion rounds, a Delphi survey, another discussion, and then a voting. And so just coming to the results section, because we had the whole process that I just described. And so early axial spondyloarthritis, according to the new ASAS definition, is having back pain, spinal back pain, including hip pain, for less than 2 years, as assessed by a rheumatologist. Thank you. Oh, no. Yeah. No, you know what's coming now. So I think, and why is it relevant? I think it makes sense that when we are doing studies in the future, that we all speak about the same when speaking about early axial spondyloarthritis, because this was also coming out of this process in a systematic literature review that some studies said less than 5 years, less than 2 years, and could be very different. And I think it makes really sense that we have an unified definition. I think this will be most likely what we are going to have in the future, that we are speaking about early axial spondyloarthritis when having typical symptoms less than 2 years. Thank you. And you see 88% of the ASAS members found this great. Then also another study that I think will have quite relevant implication for clinical studies, but also for us when we are doing observational studies. And this is the instrumentation selection of the ASAS core outcome set. And you know the OMRACT onion, and this was following the whole process. It was a long process. And this is relevant because now we have defined the tools that should be used. And I think this is, again, tools that we are already frequently using, but I think it makes also sense to have a quick look that we are making sure that all of those are included in the trials that we are doing, or when we are reading trials. So we are doing the ASDAS score. We should do, in addition, also the BASDAI, because not all questions from the ASDAS are captured. Not all questions that should be asked are captured by the ASDAS, sorry. So ASDAS plus BASDAI, BASFI, and the ASAS Health Index. And then also, if we are doing trials on medications, we should also have disease activity assessed by MRI of the spine and the sacroiliac joints. Ideally, we should check for extramusculoskeletal manifestations. We should also check clearly for peripheral manifestations, and if we want to assess structural damage, this should be done on the spine using the EMSA score. Then, fascinating study, and I think the most important thing is highlighted here also with the star, 35 years follow-up, and I think this is really something great, was seen here, and was looked the association of HLA-B27, axial spondyloarthritis, also with the subgroups, and survival. And what we can see here is not so easily seen in the graphs because not everything is in the figure, but HLA-B27 positive radiographic ankylosing spondylitis patients, both males and females, but not non-radiographic axial SPA patients, had a significantly shortened life expectancy compared to sex and age matched controls. I think this is something very relevant for us. This is something that we can also speak with our patients about. And also was seen that HLA-B27 carriage in the general population was not associated with reduced life expectancy. There's also, I mean, all of us are seeing quite regularly patients with a positive HLA-B27 coming to our clinic asking, what is the relevance for me? Do I have axial spondyloarthritis? We can exclude axial spondyloarthritis, and then we can also say, well, and this is shown here, is not having any impact on your life expectancy. What I have to say is also when seeing this data, I think it's fascinating, but I'm not 100% sure if the same results would come out in a study that we start now and assess in 35 years comparing non-radiographic and radiographic axial SPA, because I think we have to admit that it was different times then, and non-radiographic axial SPA was diagnosed differently because we didn't have MRI available, so it might have been a different patient population that was included in this study. Then the international management recommendations. Even though already presented at conferences a bit earlier and called 2022 update because it was published in 2023. I included this here as well. So the ASAS and EULAR management recommendations for axial spondyloarthritis and the flowchart that we are most likely all quite familiar with, giving us quite clear indications how to manage our patients. There are not so many new things, and I will go to the new things only because I think in the matter of time I cannot go through the whole project, and it was stated that when the indication for targeted or biological synthetic DMARD is given, TNFI, IL-17, or JAK inhibitors could be used, but current practice would be to start with a TNFI or IL-17A inhibitor. And here, I think this is a very important step forward towards a more personalized treatment approach, that the extramusculoskeletal manifestations should guide our treatment decisions. And if a patient is having recurrent uveitis, a monoclonal anti-TNF antibody should be used. And this is also the case if we have active IBD, then also monoclonal anti-TNF antibody should be used. But if we have a patient with axial SPA and significant skin involvement of the psoriasis, an IL-17A inhibitor should be preferred. And I think a point I could not emphasize more is the treatment failure, because if we have a patient having primary treatment failure, we treat him or her for an adequate time, 12 or 16 weeks, and is not responding to therapy at all. I think this should really prompt us to check if our diagnosis 3 or 4 months ago was really correct. And if this is the case, then a switch to another biological or targeted synthetic DMAT should be considered. And the information about tapering are also now included in the management recommendations. And if a patient is in sustained remission, it was not defined what is sustained remission, tapering can be considered. Very recently, also PANLA published management recommendations for axial spondyloarthritis. I really enjoyed reading, and I have seen also some of the co-authors here in the room. You will see that the algorithm is quite similar to what is also suggested by ASAS and EULA, and I think this is, again, very confirming that the view on the data is similar, but it's also having some specific insights, mainly for physicians treating patients with axial spondyloarthritis in the PANLA region that might have not been taken into account from the ASAS EULA perspective in such detail. Just shortly highlighting that if a biological DMAT is not available, this is something that we don't have in mind when treating patients in Europe, that then a JAK inhibitor can be considered, because we don't have these regulations or this, we have them available. This is so something that, and it was also stated, and this is for the management recommendations, that follow-up X-rays should not be performed in clinical routine. And I think this is also something that I could state would make sense from my perspective, because I cannot remember that I really did an X-ray of the spine and I saw one syndesmophyte more or whatsoever and said, because of that, I'm changing my treatment decision. And I think in a time where we have also MRI available, this is something that I can only emphasize, and I really enjoyed when I was reading this. Treatment withdrawal as a title for the next studies that I want to speak with you about. And here again, you have seen that this was already included in the management recommendations from ASAS and EULA, and in the same way also from PANLA. Here, sustained remission was even more defined. And speaking about IL-17 inhibition with ixekizumab in patients with axial spondyloarthritis, and I think here it really depends what kind of person are you. Are you an optimist? Are you a pessimist? And I think this will also change the way how you are advocating your patients, because I think you could see the data from different point of views, because what you are seeing here is, in the gray, that 33% remained without a flare. 1 out of 3. I think this is quite okay without treatment. On the other hand, you could argue, well, you only have a 33% chance, or you have a 70% chance of getting a flare. And I think this is important that we speak with our patients about this, and then they can make an informed decision. But really important also, if we, together with the patients, decide to withdraw the treatment and see what is going to happen, and the patient is having a flare again, and we reintroduce the drug, we see that almost all of those patients regain inactive disease or low disease activity. And I think this is something which I will definitely include in my consultation with my patients when speaking about treatment withdrawal, because this is often a topic that comes up from the patient's perspective, right? Well, doctor, I'm taking this drug now for such a long time. I'm doing perfectly fine. Do I really need to take it anymore? And now we have some data that we can share with him or her. Here, this is a bit different because it's only non-radiographic axial spondyloarthritis from the re-embark trial with etanercept. And here we can see that quite similar results, I would say. And this again gives us the question, what do we do with it? And here we have again also important things, because we can say who is having a higher chance of having a flare. And higher chance of having a flare are those patients with the positive MRI and the positive CRP. So those patients that are really active at baseline are having a higher chance of achieving having a flare after treatment withdrawal on the later run. And for those who are regaining remission after reintroduction, these were male patients with a younger age. Similar but a bit different here in the Go Back study. I do like the study design because it was not only withdrawal, but it was double-blinded for continuing the treatment with golimumab, treatment withdrawal, placebo, and doubling the interval, going on a every other month interval, and then every other month placebo. And what can be seen here? So first, I would say that the efficacy of every month and every other month is quite similar. So this gives us, again, data also for golimumab that spacing the interval might lead to quite good results in patients that reach remission after 10 months of treatment. And again, 1 out of 3 patients is also doing fine with placebo. And what you are going to do with this data is, I think this is just up to you and speaking with your patients about it. And for me, I can only share that if a patient is coming to me and is asking, can I would always say, yes, you can. You have a risk that you're coming back, but we can give it a try. But I'm not so actively bringing this to the patient, because if the patient is doing fine, is in remission, can do everything, is tolerating the medication well, based on those data, should I be the advocate saying, well, I want to put you off the drug? And then he says, well, what is my risk of getting a flare again, getting all the pain? I would need it to say, yeah, 1 out of 3. New treatments. And this is something where we in EMA countries have a most likely a little bit different view, because we are now benefiting from those results that I'm presenting, a little bit at least. And I wanted to speak first about IL-17A and F dual inhibition with bimekizumab. And I was saying this because bimekizumab is EMA approved since June. So we are currently already using it and treating our patients. And it has been approved for axial spondyloarthritis, and most likely Elaine will also speak about psoriatic arthritis. And so we already have some experiences since June, since we started them, we're able to open label administer this to our patients. And these were 2 trials that were published in the time frame that I mentioned. So it was first the 16 weeks results, and now also the 52-week data from the BMobile 1 and 2 studies. And this makes sense that we are looking at it, what is BMobile 1 and BMobile 2. And this is both radiographic ankylosing spondylitis and non-radiographic axial SpA. So we can say that bimekizumab was investigated in the whole spectrum of axial spondyloarthritis. And this will be also the way that I'm presenting it. You see it on your left side, the BMobile 1, non-radiographic, and on the right-hand side, BMobile 2. For me, it's always a bit easier to remember because non-radiographic comes first, and only when it progresses from 1 to 2, then it's radiographic. So I can remember which of the studies was assessing which patient population. And when looking here at the 16-week data, which then led to the EMA approval, we can say with a quite good ASAS-40 response. And what I would put out of it is especially that the treatment response was quite similar between non-radiographic and radiographic axial SpA. And here are the 52-week data, published a little later. And we can see here again that first, those patients that were treated with placebo in the first 16 weeks, then were really getting almost to the same positive treatment effect compared to those patients that were on drug from the beginning. And that both groups, the ones that were treated directly with bimekizumab and those that started on placebo, were continuing this response and even having a little increase in the ASAS-40 response from week 16 to week 52. Just shortly, also speaking about objective signs of inflammation here with CRP values that we can see responded well to therapy, and also here with the this is the sacroiliac joint data, also responded well to therapy. And this is the tricky case because it's not fully published yet, but I think that we cannot neglect this when we're speaking about 1 year in review. SURPASS data. And why is it so important from my perspective? Because we were always enviously looking at RA, PSO, and latest years also PSA, because their treatment decisions could really be based on head-to-head data. And I think this is what we need when we want to make good and informed treatment decisions. And therefore, I was really eagerly awaiting the SURPASS data, which have not been published to my knowledge yet. But Xenophon was presenting it last year at the ACR as a late breaking and then at the EULAR as an oral presentation. And what was done? So it was radiographic patients only with a high risk of radiographic progression, so having already existing syndesmophytes and a CRP elevation. And those patients were then treated with secukinumab in the different dosages or adalimumab as comparator for 2 years. And the main outcome, primary outcome, was radiographic progression with assessed with the MSIS score. And when looking at the cumulative probability plot, I think everyone here in the room can agree, not much difference. And I think even though it's only, or the primary endpoint was the radiographic progression, there's more in this data, and therefore I'm so excited to see the full manuscript because I really want to see are there maybe patient populations that respond better to one drug or the other, and also how is it going to be with the MRI data. And here this was also then already shown at the EULAR, also MRI data. And again here the the two secukinumab dosages in blue compared to adalimumab in red. And this is a reduction of the sacroiliac joint bone marrow edema score. And I think again here we can see that both or all three groups responded well to the treatment. And from my perspective, first, no real difference between the different dosages of secukinumab, and also no real difference or clinically meaningful difference, I would say, between IL-17A inhibition and TNF inhibition. Thought-provoking, also very recently published. And this is a case report, only one patient. Usually I would not present a case report on one patient in our year of review. But first, I think it gives us quite a good indication, published in Nature. And the implications it might have, this is a strong might, are so important for all of us here in the room. I think that I wanted to highlight it and especially discuss it. Maybe you have thoughts. And here was a targeted T-cell depletion for TRBV9+. And this goes in the direction of the T-cell receptor and the atterogenogenic peptide concept. And so here a group was having a patient with radiographic axial spondyloarthritis who was treated with many TNF inhibitors previously, NSAIDs, also had stem cell transplantation from this group earlier on, and had again a flare under TNF inhibitor, and was then put on treatment with this specific targeted T-cell depletion. And when looking at the clinical data, this seems quite promising. You can see here, it might be a little too small, but it was given over a certain amount of time. And then they saw that the T cells are coming back and clinical features were also coming back. So they re-administered it, and then they started with a regular treatment of every 4 months. The patient, at least from the data that they presented here, was responding very well to therapy. It was having also the same results in the pharmacokinetics, especially what you can maybe see here, that cells were coming back a little and then was re-administered, and then the patient had symptom relief quite instantly. It was well tolerated as described. And I'm not 100% sure what this really will bring us, but I'm excited to see more data and more patients, longer term follow-up, because if this would be the case, I think this could be also a promising treatment target. And with this, I'm at the end of my presentation. I thank you for your attention. I'm happy to get your questions and especially your thoughts.
First, it's two questions. One of them is, what is the definition of sustained remission in AxSpA? So theoretically, I would think when do we taper is after a patient had sustained remission for a certain period of time. Do we have this definition, consensus at least or not, before we attempt taper? The other thing is, in some of the studies, immediately they stop the medication without trying to taper and then withdraw. Do you think by tapering and then withdraw, this could be more promising?
I don't have the data for this, but I personally think it could make sense. There is some data from, I think, the Danish registry. Mikkel is not in the room, right? I have not seen him here. Where it had the same effect, that also when tapering, and at a certain amount of time, or they were spacing the interval, then the flares were approaching again. So I think, from my perspective, spacing the interval to some extent is great and doesn't come with a relevant negative implications, but only until a certain point of time. And so I can only share what I'm doing in my clinical practice, and this is the same with the agreed upon definition on sustained remission. There is now such a agreed definition. PANDA was now introducing their definition in the management recommendations, but this is, at least from my knowledge, is not data-driven, or also not a strong expert process went through it. So I think it makes sense to have such a definition when speaking about it. And in my clinical routine, this is exactly what I tell my patients when they come to me and I explain about the treatment, and they ask, and do I have to take this forever? And I say, well, I don't know, but this is the data, and I would first suggest to have really sustained remission for 12 months. This is how I'm doing it in clinical practice. It might be even, maybe it's only 6 months. I don't know what the patient needs, but I say when you're in remission for 12 months, then I'm really there to reduce the intervals.
Thanks a lot. That was a great summary. How generalizable that case report is remains to be seen for sure, as you correctly pointed out. The enrichment of V-beta 9 was something we had published since 2017 and led to some rationale for, because we think there is clonotypic restriction in TCRs. What we subsequently found is that V-beta 9 is not necessarily dominant, and between patients there's a lot of heterogeneity. Even in the synovial fluid, T-cell repertoire versus peripheral blood, there's heterogeneity. So it may be very specific, like you may have to specifically go after a sequence of TCRs to decide what the target's going to be. I mean, it was a pretty dramatic story, although atypical, but not many of our AS patients get bone marrow transplantation either, right? So it was an unusual sequence, but it's very provocative. So thanks for highlighting.
I could not agree on everything that you said more than, because I think, and you said this, when I was reading the case report, I was also seeing that you have published to this topic previously, and I'm not sure about the implications. This was what I wanted to really, and I have skepticism, I have to clearly say this, but at least it is something that we need to follow up how this will develop further.
Okay, no more questions. Thank you so much.
Okay, hello everyone. My name is Soha Dolatabadi. I'm a rheumatologist in Los Angeles. I hope everybody is awake and alert. Yes? Shall we continue? Very good. I have the honor and pleasure of introducing Dr. Elaine Hosny here as our next presenter. Before I make that official introduction, I want to let her know that I met her first time when I was a fellow at Cedars-Sinai, and she was invited by my wonderful program director, Dr. Weissman. And she left an everlasting impression on me where she presented all her data with smile and very friendly, so I've been very interested in her work ever since. She is the vice chair of the Cleveland Clinic's Department of Rheumatic and Immunological Disease, director of its Arthritis and Musculoskeletal Center, a Schultz Family Chair of Translational Functional Medicine Research. As you all know, she has multiple publications in psoriatic disease. Her research focus include, but it's not limited to, development of innovative patient-reported outcomes and screening tools for psoriatic arthritis. Her works has earned her numerous awards, such as a Physician Scientist Development Award and a Clinical Investigator Award from ACR. She's also very active, and she sits on multiple committees, medical scientific committee for Arthritis Foundation, steering committee for GRAPPA, and also board of directors for National Psoriatic Foundation. Dr. Hosni, the podium is yours.
Thank you. Hello, everyone. So glad to be here. I wish my parents were here to hear that. Thank you, Soha. That was so sweet. Soha and Mohammed have been so great at keeping us organized for this event, and it's pretty taxing to get this event going with all the stuff that's going on in ACR. So take a deep breath, everyone, and hopefully this will be a fun ride through the year in review. When I was asked to do this, I was like, oh yeah, it's not too bad. And then when I got down to the literature, I was like, oh my gosh, this is going to be tough. So I decided to have a different way of doing this. And these are my disclosures. This is sort of the topic of what I'm going to talk about. I think you guys have been saturated with safety and efficacy data here at the ACR meeting. So I'm decided to really pick some articles that I think are interesting and hopefully will change your practice a little bit, but I'm probably going to take a little step down from PSA therapeutics because I just feel like there's so much out there. So I will give you a little summary, but I'm really going to focus on some of the things, management of PSA, some interesting translational studies, some advanced imaging, and then I know we're going to hear from Walter, and then a passion of mine, which is wellness and integrative medicine and how we care for our patients. So I'm going to start with this because I highly doubt any of you are going to come visit me in Cleveland. So I'm going to take you through a little tour because then maybe you'll be a little more interested. So this is the arcade. It was built in 1890 with a large bit of funding from John Rockefeller. And this was actually known as the first indoor mall in the United States. So just a little tidbit. All right, so I shared with you that I wasn't going to go head over heels for all the therapeutics, but this is a chart that I use for my fellows and residents. So what you can see here is looking at all the treatment options that we have for spondyloarthritis, so psoriasis, psoriatic arthritis, and ankylosing spondylitis, and then you see the drug classes on your right. And then you see a bunch of dots. So basically the green dots are the ones that are approved, the yellow dots are kind of still in trials, and then the red dots have stopped because of ineffectiveness and things like that. And what I don't want you to read every line, but I want you to understand that the red dots, there's a lot of red dots on the ankylosing spondylitis side compared to the psoriasis, psoriatic arthritis. So we still have ways to go for treatment. So just wanted to give that overview. So I'm going to try to sum up as much as I can of the FDA approved. I know we're from all over different countries, but I'm just trying to highlight some things with IL-17. So, you know, with secukinumab, there's an IV formulation that's out this year. There's some more studies in enthesitis-related arthritis and JRA. There's continued studies on safety and efficacy of these drugs. Ixekizumab, for example, has some great new data on nail psoriasis. As we all know, that's a really difficult manifestation to treat in psoriatic arthritis. In terms of the IL-23s, we know that many of this at this meeting, such as risankizumab, has continued to have great data, keepsake 1 and 2, long-term data looking at improvement in safety, efficacy, and health-related quality of life. And then the JAK inhibitors, we all know there's some new data this year on enthesitis. So I'm just going to highlight 1 or 2 studies within those that we're already familiar with. So guselkumab and serum biomarkers. So the reason I picked this is because in addition to just showing us efficacy, what they did in the Cosmos trials was look at baseline biomarker data. And the reason I found that interesting in this TNF inadequate responder group comparing to healthy controls is because we're always trying to figure out which drug we're going to use first. And is there a way that perhaps some of the biomarkers could help us? So here I listed all the biomarkers that were used in the Cosmos study, everything from interferon, IL-10, you can read the list. And what they did was they looked at it at baseline and then they looked at it at week 24 response. And what they found was that guselkumab, not surprisingly, was able to reduce some of these effector cytokines in this pathway. And they were also able to look at a potential role at predicting response. So those that respond and those that didn't respond had different biomarker panels. So whether or not we could use that in the near future. I also wanted to highlight UPA, which we all know has had established phase 3 clinical trials in many of our immune diseases, including RA, psoriatic arthritis, and AxSpA in the select PSA 1 and 2 trials. But I wanted to highlight those psoriatic arthritis with axial involvement. So this is what this study was showing. And as we all know, axial involvement is not that easy to define in psoriatic arthritis. So what they did was they had a cohort looking as defined by the investigator, and then they further said, I'm going to look at those that respond by those that are labeled axial involvement with the investigator plus a PRO. And you can see here the percentages. This is a post hoc analysis in their database looking at just the select group that had axial involvement. And what they found was a greater proportion had achieved BASDI 50 in the UPA group versus placebo, and then also in that second group, which was defined by the investigator plus PRO, also had achieved BASDI 50 in the UPA 15 compared to placebo. So they looked at this all through week 56, and they had comparable safety data as well in this group. Now I'm just going to turn our attention to those that, at least in the United States, we do not quite yet have approval. But as you heard from Fabian, many of you may have already been using bimekizumab. So about 3 weeks ago, this was approved for psoriasis. So in the derm world, they probably have some familiarity. But in terms of us as a rheumatologist, it has not been approved in the United States. Just to remind you, this is a selectively inhibits not just IL-17A, but also F. And these are the list of the different trials that have shown great superiority, improvement in both skin and joint compared to placebo in different populations. So B optimal, for example, is bio-naive, while the B complete are people that are inadequate responders. And all of their trials have shown some good efficacy for both skin and joints. And we will hopefully hear a little bit more about PSA approval. And I know many of you in other countries might be already using this. I do want to highlight brepocitinib, which is a TYK2/JAK1 inhibitor that was studied in active psoriatic arthritis in 218 patients. You can see here, randomized to 10 milligrams, 30 milligrams, and 60 milligrams versus placebo. And then those that didn't respond at week 16 were advanced to brepocitinib 30 and 60 milligrams. Their primary outcome was ACR 20, so a little bit lower than what we normally do at ACR 50, but they also had the usual suspects for the secondary outcomes, which is, as you can see there, both the ACR scores and the PASI scores, as well as looking at safety events. So what they found in this study for brepocitinib at week 16, as you see in these arrows, compared to placebo, that they had some success in their efficacy compared to placebo. So ACR 20 was in the 74% range, ACR 50 you could see there was in the mid-40 range, and then ACR 70 was in the 20-23% range. And then they looked at this same group out to week 52. Which you see here with some sustained improvement as well. So this is something we should probably look, getting excited for more information on this in the near future. So this is Playhouse Square, which is an area where in Cleveland where we see all of our theater district, and this chandelier is outdoors, and it is, at least what they tell Clevelanders, is it's the largest chandelier, outdoor chandelier that is around. So another thing for you to visit. Okay, so we're going to turn our attention to trends. So in the Toronto cohort, I highlighted this, where in this large cohort of 571 psoriatic arthritis patients, they followed them out for 20 years. And they wanted to look at how long people stayed on the biologics. They were only able to really tease out TNF inhibitors and IL-17 inhibitors because JAKs and others, they were too small, so they weren't able to comment on that. So these are the two biologics that they found. These are the survival curves for that, and you can see there's some splits. I know it's really hard in the back of the room, but I did do another slide to kind of give you the key findings. So basically, looking at this large group over 20 years, their 3-year persistent probability looks like sertolizumab had the highest persistent. Interleukin-17 inhibitors had the lowest in this group. However, when they looked at the group again and saw whether or not it was a first-line or second-line treatment, it actually mattered how persistent it was. So sertolizumab, if it was used as a second agent, they had a lower drug survival, even accounting for some selection biases. Then they also looked at other risk factors, such as drug discontinuation, and they saw that if you had higher education, it was associated with a lower discontinuation rate, while higher tender joint count and older age led to linked to a higher discontinuation rate. In another similar study looking at long-term effectiveness of ustekinumab and TNF inhibitor. So the reason I write about this is because many times in my office, I write for a biologic, and I wholeheartedly believe they're always on it. But this data is telling you they're not always on it. So I don't know what happens to all those prescriptions that I write. But in this PSA bio study by Laura Gossick's group, 895 were followed, and they had ustekinumab versus TNF inhibitors. They followed them every six months, and they saw very comparable persistence of drug use of ustekinumab versus TNF inhibitors, good efficacy as well. So the interesting point here is that people that were on ustekinumab had a lot lower rate of adverse events, even though both groups stayed on the medications around the same time. This is a big area of interest in people that do psoriatic arthritis work is how do we find the patients with psoriasis that are going to get psoriatic arthritis? So this was the PRESTO study that was done in 2023. It looked at developing this tool to identify, is there a way that we can identify? There's really fancy ways to identify, but this paper, interestingly enough, looked at just common clinical factors that you and I would have in practice, and we looked at those clinical factors to see in the PRESTO trial whether or not it would develop, if they could predict psoriasis to psoriatic arthritis. So they looked at 1-year factors and 5-year factors, and you can see all these factors. These are factors that you could get in your office. The age, gender, family history, back stiffness, nail pitting. And what they found was that based on their statistical models, that they were able to predict, just from these clinical factors alone, they were able to predict those psoriasis patients that would go on at 1 year and 5 years into psoriatic arthritis. So this may have implications that there may be a combination of just normal clinical risk factors that we get in clinical practice that could help us determine who's going to switch. All right, this is probably one of our more famous icons. This is the Rock and Roll Hall of Fame, or the Rock Hall that we call it in Cleveland. So we worked really hard to get this in Cleveland. It is on Lake Erie, so it's a beautiful water view, and this has all the memorabilia that you could think of all the rock stars that you can imagine. So we're very proud of this, but definitely a good place to visit. All right, so we're going to turn our attention to more translational studies. I found a couple that I thought was pretty interesting looking at the microbiome. We can't get away with this meeting without talking about microbiome, so I'm just highlighting some studies here, looking at a study that looked at cutaneous microbiome in psoriatic diseases, and they were able to distinguish between changes in alpha diversity and beta diversity plots between psoriasis and psoriatic arthritis, and even within the psoriasis patients in their lesion skin and their non-lesional skin. So I think this was exciting work. And then to lay another layer on that, you can't really get away this meeting without talking about spatial transcriptomics. So this further stratifies the different types of psoriatic diseases that we see. And the value of spatial transcriptomics, in addition to looking at the cellular makeup, and defining all these interactions cell to cell, this is actually able to define clusters that probably could not be defined with just single cell RNA-seq. So I think we're getting deeper into the way that we can describe this. Now, what does this actually mean when we can find these clusters? being that we can see differences, I think hopefully this will lead to us soon, especially with the, this is out of Jose Scher's group, maybe further looking at these different clusters if we can define. So I couldn't help but put all these fancy pictures that they have and all these different colors, but what you can tell from this is that we can actually look at distinct clusters. You can see the different colors that correlate with the different disease severity. And then further on, they structurally define different cell cultures that are enriched in different types of lesions in these psoriasis patients. And then they can, on the bottom graph, they can look at immune cells that actually migrate from different areas, and they see differences between healthy skin and diseased skin. So these are hopefully spatial transcriptomics world will help stratify some of these psoriatic disease severity, and we can start looking a little bit deeper about who may respond to certain drugs and who may have a more poor prognosis or better prognosis. Another translational study that I thought was interesting is the FLORA trial. So this was looking at 31 patients with active PSA. They followed them out to 26 weeks, and they randomly allocated them to fecal microtransplantation and sham, and they were looking at markers for intestinal permeability. And what they were able to predict is that based on their fancy LMR test, which is a lactulose to mannitol ratio, different things that predict intestinal permeability, they were able to look at different profiles for those that fail and those that are responders. So this may be the beginning of looking at poop in a different way and actually being able to tell you whether or not you're a responder or non-responder. All right. This is the West Side Market. This is home to produce and butchers, and this is like a really cool place where you can buy all kinds of baked goods, foods, and it's on the West Side. It's just a very famous marketplace that we are very proud of. All right, I'm going to end towards the second half of the talk, really focusing on lifestyle and imaging. So here, looking at lifestyle, there's not 1 week that goes by that a patient asks me, what can I eat for my whatever, RA, psoriatic arthritis, right? So you go to the literature and you see all these different diets in these blue boxes. People have looked at Western diets, Mediterranean diets, gluten-free diets. So unfortunately, based on everything that I see, there wasn't a single diet that we could recommend, but what was really interesting is that obesity, which is a modifiable risk factor, was associated with increased risk of psoriatic arthritis and increased disease activity. So those patients with obesity had higher DAPSA scores, had poorer response to therapy. So many reasons to talk to your patients about obesity. And then just to further support this fact, the REFLAP study, which is a multi-center international study that looked at over 430 patients. Once again, they also saw that obesity was associated with lower odds of being in remission or MDA, minimal disease activity. So another reason is that, those patients that are obese with a higher BMI, they also don't respond to therapy. So we also want to look at lifestyle modification. So in addition to obesity, what else can you tell your patients to do? So this was a rather large study, which I thought was interesting. They looked at 7 different databases. They had thousands of articles, and their final results were these 8 studies that looked at lifestyle modifications in psoriatic arthritis patients. Unfortunately, none of them were high enough quality to say that one lifestyle is better than the other, but they did, in summary, saw improvement in physical activity, diet, weight loss, smoking, and if you guys can see in the back of the room, the very last one is mud bath therapy. That intervention did reduce synovial inflammation by ultrasound. So more to come on that. So this study I found really interesting is a lot of patients like to exercise, and they ask, okay, how much exercise can I do and will it hurt my joints? And how many of us really know what to say, right? So does high intensity exercise any worse than regular exercise, any worse than doing the treadmill? So I found this really interesting. So they asked, does high intensity HIIT training, I don't know how many of you guys do HIIT training, do you think that that is a good advice for somebody with psoriatic arthritis? So what this group did was look at patients randomized either to doing HIIT or doing just regular exercise. And they did a baseline, and then 24 weeks later, they ultrasound and MRI'd all their joints with these two different exercises. And interestingly enough, they found that there was no evidence that, that they could objectively measure that even if you were doing high intensity of exercise, that you were still okay. They did not see any differences between these two groups. So, bottom line, exercise away. That's good. You won't hurt your joints. Okay, so last but not least, this is the Cleveland Cultural Gardens. So along one of our major highways, there are 35 to 38 different gardens along the way that represent different countries. So I just picked, one garden, but it's just a very beautiful cultural highway that we have right in Cleveland. So I know we're going to do some more imaging with Walter, but I just picked a couple that I thought was a little different. So that's using PET CT. I know this is not always easy for us to order, but in this very small study of 16 patients with psoriatic arthritis, they were able to specifically find new bone formation, which is something that we look for to help us know that this is a psoriatic arthritis patient, and they were able to look at PET positive patients. And then lastly, looking at another imaging study in psoriatic arthritis. A lot of us know that swollen joints are something that we want to try to control. But what about tender joints? Is tender joints without any swelling, is that something that we worry about, care about? So this particular study looked at radiographic outcomes in RA and in psoriatic arthritis, and looked at tender joints, looked at swollen joints, and wanted to see if there was any difference. And interestingly enough, in this small trial, they found that psoriatic arthritis patients with just tender joints, not swollen, did show some radiographic progression. And then I wanted to just pick an area of genetics. I think we are always hoping that there is a lot that we can glean from all these genetic studies, and we know that it takes large collaborations to come up with conclusions. So this is a narrative review that was done this year, looking at genetic risk factors for classifying psoriatic arthritis risk and diagnosis. And this is a chart that shows that IL-23R and HLA-B have been found to be PSA-specific loci across multiple independent data sets. So I thought this was nice to highlight in this world that's really driving leaps and bounds in our genetic world. So this is our skyline. We are a city that's on the water. This is one of our prettier buildings all lit up at night. And that concludes my talk. I wanted to thank the people that has helped me with this talk, because obviously there's a lot of people in my lab that I work with that have helped me create this presentation. So I just wanted to acknowledge them as well. And this is where I work. So thank you very much.
Two questions. First, you to the UPA Axial PSA, because you were highlighting that it is tricky because we don't have a unified definition for axial disease, and showed a response in BASDAI. And I just want to hear your opinion, because BASDAI, we know, has also questions for peripheral disease, fatigue, general well-being in overall. So I think if the psoriatic arthritis peripheral and maybe skin is improved, disease activity is reduced, the BASDAI score will go down anyways. Do you really think it is the effect on the actual disease, or should we rather have a better outcome measure for actual PSA as well?
Yeah, I think that's a great point. I do hope that there are, better markers. This is what this study used. But I also do think that BASDAI, at least when I use it clinically, does correlate well with the axial symptoms of my patients, but I also understand your comment where it's not probably as a complete composite as we want for axial. Do you use any more specific axial measure for these patients to see that?
No, there's nothing out there. This is exactly the problem, right? I think maybe the just back pain question would be a bit more specific, but still not the best. And I think I just wanted to highlight and hear your opinion.
No, that's a really good point.
And also for the diet, you said that there's no diet out there that could be recommended, but I always recommend Western Mediterranean diet to my patient, and I think this was also shown on the slide, so can you comment on this?
Yeah, so the New England Journal has I think one of the most comprehensive diet study looking at the Mediterranean plant-based, showing a positive effect. So the one that I highlighted was just specifically in psoriatic arthritis, and all of those diets showed some benefit. I think what I was saying that none of them were better than the other.
Okay,
So,
thank you.
Okay.
Our next speaker is Dr. Walter Maksimovic, a professor and medical scientist in the Department of Medicine, Division of Rheumatology at the University of Alberta in Canada. He is the 2012 recipient of Distinguished Investigator Awards from Canadian Rheumatology Association. He is the past chair of Scientific Committee of Canadian Rheumatology Association. His primary research interests are the imaging and treatment of spondyloarthritis and the clinical validation of biomarker technologies for rheumatic diseases. He has published over 350 research articles and is a member of numerous international societies related to arthritis research. He has spearheaded numerous international collaborative networks that have culminated in the development of multiple scoring systems based on imaging and biomarker technologies for use in both diagnostic and therapeutic settings, as well as clinical trials. Dr. Maksimovic will be discussing a very important topic, which is pitfalls and mimics of imaging spondyloarthritis.
Thank you so much, Mohammed. Good evening, everyone. It's a great pleasure and privilege to be here and talk about something that I feel very passionately about. So I thought by 7 o'clock on a Sunday night, people are going to be pretty tired and may have walked the 10,544 steps that I've already walked today, and maybe won't be that interested in seeing too much around odds ratios and 95% confidence intervals. And so I thought, besides informing, I should also aim to entertain. So that will be my intention. So let's just begin. You know, I've just spent the last 3 years working on the classic program, and also as a central reader of the AXIS program. In doing these programs, particularly the classic program, one of the obligations was to have a discussion with our local imaging readers. And so I engaged in about 80 webinars with local rheumatologists and radiologists over a period of 2 to 3 years during the COVID pandemic. And there were some really interesting questions that kept coming up that posed challenges in MRI interpretation. And what I thought I would do is highlight some of these questions and then present to you a standardized format for interpretation, and then move through some golden rules around interpretation. So here's some of the questions I'm going to focus on. When is BMA in the sacroiliac joint XPAR or not? Can I still make a diagnosis of XPAR if there is no BME? When does joint irregularity become an erosion? How do I decide if fat in the sacroiliac joint is physiological or XPAR related? You know, when surveys have been done and evaluations of consecutive patients presenting with suspicion of XPAR and back pain symptoms, about 30% or so turn out to have alternative diagnoses. One of the few the things that I really want to emphasize is that, of course, we're not just evaluating imaging, we're evaluating the patient. And certainly interpretation of imaging very much depends on the age, the gender, and the clinical features. And then size and extent and intensity of lesions on consecutive slices has to be evaluated. How large does a lesion have to be before we feel confident in making a diagnosis? The location and distribution is really important. One of the things we don't really emphasize that is very much emphasized among radiologists is the importance of multiplanar imaging. And I'll show you shortly what I mean by that. And then what is a really important principle in evaluating images is contextual interpretation of all MRI sequences so that you have as much information as possible. So when we start discussing standardized approaches, what I would really like to do is to begin with a bit of anatomy. And it's really important to understand the anatomy of the sacroiliac joint to understand why we image the joint the way that we do and what approaches are taken to optimize the evaluation of imaging in the sacroiliac joint. So the first thing is that the joint, the cartilaginous portion of the joint, in males at least, is a C-shaped structure like this. So that's why we take consecutive slices that are parallel to the posterior surface of the second sacral segment. And we take a series of consecutive cuts, each about 3 millimeters in depth and 1 millimeter between slices. And typically there's about 15 to 20 slices through the sacroiliac joint. And only the inferior third, as I've outlined here, is lined by synovium. So often you hear people talking about the synovial portion of the joint when really they're referring to the cartilaginous portion of the joint. And then the anatomy of the joint's a little bit different in men and women. And this is really important to understand when we think about false positive bone marrow lesions. So here's what a female joint looks like, and particularly the cartilaginous portion. See, in a male, it's a C-shaped structure, but most of the stress on the joint is on this anterior portion of the joint. And you can see that stress is even more prominent in this anterior portion of the joint. So again, in women, we're taking the semicoronal cuts, consecutive slices through the cartilaginous portion of the joint. But what's also really important is to image the joint in a perpendicular direction to the semicoronal one, because we really want to understand where exactly is that lesion located. And as you take cuts through the joint, you're taking cuts through blood vessels, crostal joints, and then as you go further back, you're going to be making cuts through the ligamentary portion of the joint. So anteriorly, you're mainly going to be in the cartilaginous portion of the joint, and then there's going to be a point in more posterior slices where the ligamentous portion of the joint is going to appear in the middle. So what is the systematic approach to imaging that I was referring to? And there's now international consensus around this. What's the optimal way to evaluate a joint, the sacroiliac joints? And what we really want to be able to see, and this protocol has been endorsed by a joint committee of musculoskeletal radiologists, 2 rheumatologists from the ASAS Spartan group. And what we really want to see are sequences that identify fat, that are fat sensitive. We want a sequence that will identify fluid, a water-sensitive sequence, and in addition, we want a cartilage-sensitive sequence. So you should be looking at all of these images at the same time on a screen, evaluating each sequence in a contextual manner, because they each highlight something different. They're complementary to each other. So the fat-sensitive sequence is, if you like, the workhorse. This identifies, as you can see, subcutaneous fat, but also the adult bone marrow has a considerable amount of fat, so it has a bright gray appearance on a T1 semicoronal scan. And this is a water-sensitive sequence. You can see the presacral veins, you can see the cerebrospinal fluid at the back, and you can see that it's also a fat suppressed. So it's not just fluid sensitive, it's fluid sensitive and fat suppressed. So that would be your STIR semicoronal. So this is the T1 that I was referring to, the fluid sensitive sequence. Hopefully there's enough annotation to understand what I've said already. Here's the axial scan, and you'll see in a minute the importance of the axial scan in an evidence-based way. And then here is the cartilage sensitive. The cartilage appears much brighter, and you can see there's accentuation of the cartilage subchondral iliac bone interface. And that's so that we can detect erosion in a more sensitive way. And the simplest sequence is a T1 fat sat, but now there's very thin slice sequences, a 3D gradient echo fat sat. And this will give you incredible detail, as you can see here. So here again is the fat sensitive sequence. Here is the STIR sequence with the presacral veins, fluid sensitive. And here is a beautiful 3D gradient echo where the interface between cartilage and subchondral bone is crisp, high detail, and you can evaluate erosions to a very high degree of sensitivity. So here's an example of a patient with all four sequences. This is how we should be evaluating scans in 2023. We need a T1, we need the fluid sensitive sequence here with the bone marrow edema, the T1 fat sat here, the erosion sensitive sequence, and we need the axial sequence that shows us exactly where the inflammation is located. And I'll show you far more examples very shortly. Here's a 31-year-old female, short history of low back pain, normal pelvic x-ray, B27 negative. This patient was a candidate for an advanced treatment, having failed non-steroidal anti-inflammatory lesions. The bone marrow edema lesions here are fairly obvious, but you can also see what we find quite typical in patients presenting with undiagnosed back pain to a rheumatologist. They have both active inflammatory and structural lesions. 90% of patients presenting with undiagnosed back pain have both. There's relatively few patients, if all that you can do is interpret bone marrow edema lesions, you're only getting part of the information. So here's a much more subtle case. Now we're again showing what I call the 3-sequence, 2-plane protocol. That's what we ought to be remembering. The 3-sequence, fat cartilage water, 2-plane semicoronal axial protocol. Now here we've got a 22-year-old female with a 2-year history of low back pain. Also now, potentially, a candidate for a biologic. How certain are you you've got the diagnosis right? Now, the bone marrow edema lesions are not that obvious. And what you mainly have is some subtle erosion on the cartilage sensitive sequence in both iliac bones. You have evidence of some fat deposition at the site of the erosion, a typical example of backfill, and you have some evident erosion on the axial sequence as well. But the amount of bone marrow edema is really quite minimal. So, evidence base for the advantages of multiplanar imaging. And this is just a beautiful figure from a Swiss study, and the first author sitting right in front of me. And this is a study that evaluated pitfalls in imaging and the implications of using both semicoronal and axial images. You can see here, here's a scan from the anterior portion of the joint. Here's a scan from the middle portion of the joint. And now we're getting to the posterior portion of the joint. And this is what the corresponding axial scan looks like. The horizontal lines here divide cartilage anteriorly from ligament posteriorly. And we can see here that we have evidence of bone marrow edema in the iliac bone. And we see that this is evident mainly in the anterior portion of the joint, and relatively little is evident posteriorly. So the bone marrow edema is primarily evident in the cartilaginous portion of the joint. But this is where it gets interesting, and where the axial imaging helps you to sort out what may be a false positive. So let's say we're starting off with the semicoronal scan here. There's a blob of bone marrow edema in the left inferior iliac bone on the stir sequence. We can see, in fact, that that blob on the axial sequence is not in either the sacrum or, in fact, the iliac bone. It's, in fact, blood vessel. And it's what we call partial volume effect. What's happening is the slice that's taken has taken a cut through a blood vessel, and that's kind of superimposed on the inferior portion of the iliac bone. You can see that the axial sequence localizes it very precisely to a very focal area of high signal that reflects blood vessel fluid in a fluid-sensitive sequence. Here's another example of what could be misinterpreted. Is this abnormality here, is this really an abnormality, an erosion, or could it be something else? So this is again an example of an axial sequence which shows you, in fact, that this is a ligamentary insertion. So there is some bright signal, as often there is around a ligament. There are blood vessels around ligaments, there's fat around ligaments. And this is just an indentation where the ligament is attaching to bone. This is a ligamentary insertion. There's nothing within the bone marrow. Okay, so this is exterior to the iliac bone. Here's an example of another false positive. There's bright signal, it's very focal, and it's got a smooth contour around it, surrounding it. And again, we see that this is evident in the iliac bone. It's got a very distinct border to it. And this is a good example of a bone cyst. So this is a fluid-containing cyst. And now we have an example of scanning in runners before and after running. And you can see here that if we only use the semicoronal scan, we have about 35% of runners, there were 20 runners scanned before and after running. And we had 35%, 7 runners, who were considered to have an ASAS positive MRI. So this bone marrow edema that you can see here in the inferior portion of the iliac bone. And you can actually see here that you have also on an anterior slice, you have bone marrow edema in the anterior sacrum. And these are both red flag regions. These are regions of high stress. In the anterior portion, you can see the bone marrow edema is right at the anterior edge. Now, you remember the anatomy of the sacroiliac joint and the cartilaginous portion. It's right at the anterior edge of the ilium that you see the stress, the ilium and the sacrum. So this situation, this localization, this very focal bright signal in the postero inferior ilium, where you have attachments of ligaments and tendons, and right at the anterior portion of the ilium and the sacrum, these are regions of high stress. And so if all you see is one or two slices with bright signal in these locations, you have to be very careful. Now, when you image in two planes, it's very obvious that this is very focal bone marrow edema in the very anterior portion of the joint, absolutely typical of mechanical strain. And so when you combine imaging in both planes, you can see the frequency of an ASAS positive MRI goes down to 20%. And the false positivity is reduced once you have accurate localization of the bone marrow edema signal. Now, here's another example of interpretation. Here's a 44-year-old female. She has a 10-year history of psoriasis and a psoriatic arthritis affecting her hands and feet. And she has lower back pain and long history of psoriasis. And again, she has very symptomatic joint pain, despite taking anti-inflammatories. Not very much to find on physical exam, but she does have some tenderness around the sacroiliac joints. And this is a scanning. Now you look at the scan, and this is an anterior slice, here's a posterior slice, and you can see that she has some bright signal in the anterior sacrum. So should this patient get a bio-targeted synthetic DMARD? So this bone marrow edema was isolated to just the first two slices. So this is a good example of false positive bone marrow edema that does not warrant, in fact, further treatment. This patient has a degenerative basis to the bone marrow edema. So some golden rules. In the anterior sacrum, focal bone marrow edema 1 to 2 centimeters in the anterior sacrum, or the ilium on 1 or 2 slices, that's a red flag zone for mechanical strain and or osteoarthritis. What may be helpful is deep, continuous bone marrow edema. So there is evidence from systematic studies that deep bone marrow edema, at least 1 centimeter from the cortical margin, may be more suggestive of axial SPA. But you have to be careful, as I'll show you shortly, in postpartum women. Similarly, focal bone marrow edema in the postero-inferior ilium on 1 to 2 slices, that's another danger zone. And contextual interpretation with structural lesions, if that is positive, that is more indicative of axial spondyloarthritis. Now, what are some of the other abnormalities that may mimic sacroiliitis? So here's an example of a 30-year-old woman with recurrent lower back pain and right-sided buttock pain for 3 years. And you can see that there is what appears to be an abnormality in the right sacroiliac joint. Now, you can also see it's in the anterior slice. You can see on the fluid-sensitive sequence here that there's a little bit of bone marrow edema, but you can also see that the cortex is intact. And if you weren't certain whether there might be, for example, an erosion there, because the signal is very heterogeneous. It's very difficult to interpret. Now, this is the advantage of having the 3-sequence and the additional axial evaluation. So you can see on the T1 FATSAT here that in fact there is no breach of the cortex. There is a dysmorphic iliac portion. The bone is just slightly abnormal. And you can see that the bone marrow edema on the axial sequence is very anterior, typical of a mechanical problem. And if you still weren't convinced, you could do a low radiation CT scan. And you can see that the cortex is very nicely preserved. There's a little bit of sclerosis, but there is a difference in the shape, but this is not axial spondyloarthritis. Transitional vertebrae. Here's an example of a transitional vertebrae, a thick transverse process articulating with the superior border of the sacrum. That may be associated with bone marrow edema and is a good example of a false positive. Again, you can see here in anterior slices, the bone marrow edema may extend right to the subchondral bone. Now, one of the situations that often causes considerable challenges in interpretation is the postpartum woman. And osteitis condensans eili. So how do we approach interpretation of findings in the postpartum setting? Well, here's a recently published manuscript, and in this study, women were systematically evaluated by MRI at 20 weeks of pregnancy, and then also at 3 months and at 12 months postpartum. And you can see here examples of a panel, T1, the coronal stir, and the axial stir. And this is a relatively anterior slice, and similarly at 12 months. And what you can see is that there is bone marrow edema in these anterior slices. And if you do the axial sequence, you can see again that the bone marrow edema occurs in regions of stress. So OCI very much resembles what we see in the setting of osteoarthritis and mechanical strain, athletes, runners, and so on. But interestingly, what I found quite interesting is this is already evident in 62% of women at 20 weeks of pregnancy. And in fact, there's as much as at least 4 sacroiliac joint quadrants affected with bone marrow edema in 41% of women at 3 months postpartum. You develop quadrants just by drawing a line through the joint cavity and then drawing a perpendicular line midway, and thereby you can generate quadrants. And even at 12 months postpartum, there can still be a substantial amount of bone marrow edema. You can see here at 12 months, the amount of bone marrow edema is reduced, and now it really looks very typical of a mechanical strain situation. But what may be really very helpful is that erosion is very atypical. And I think it would be very helpful to get the additional sequence, for example, a T1 FATSAT or a 3D gradient echo with FATSAT, so that you can really identify the cartilage exquisitely and the contrast with subchondral bone. So what these investigators found was that the presence of erosion can be particularly helpful in distinguishing OCI from and postpartum changes from axial spondyloarthritis. So here's just another example, and this is just demonstrating the development of sclerosis as well as the bone marrow edema signal. Now, sclerosis can be difficult to distinguish from erosion. And you can see that bone is dark in all sequences. So bone is boring to an MRI, and it will be dark on all sequences. And it can be quite difficult sometimes to determine if in fact there might be an erosion, particularly on a T1. So here, you can see here on this T1 FATSAT that this really helps you to evaluate the cortical surface, and it really does appear to be smooth and regular. So this sequence, the 3-sequence approach, the fat, cartilage, water, 3-sequence approach, can be very helpful in distinguishing. Just some more quick examples. An absolutely classic example of strain-related bone marrow edema, anterior slice in the sacrum, and you look at the axial sequence, and there is bone marrow edema in the very anterior portion. And then here's another example of what osteoarthritis might look like. So this may occur already in the 4th decade of life. And you can see here, you might wonder, well, is there an erosion here on this T1 weighted sequence? You always get a T1 weighted sequence. But what you should also get is the T1 FATSAT or a 3D gradient echo. You can see the osteophytes, and you can see that the cortex is in fact very smooth. The dark region indicating the sclerosis. If you're uncertain, you can get a low radiation CT scan. So that's osteoarthritis. What about DISH? So you can see small degrees of bone marrow edema, less than 4 sacroiliac joint quadrants in about up to 20% of patients. This was a systematic analysis. Fat lesions also in about 30%, less than 5 sacroiliac joint quadrants. Now here you have the 4 images that you really should be looking at: the fat, the water, the cartilage. And you can see how this beautifully indicates the contrast between the bright cartilage and the subchondral bone. And you can see the bone marrow edema again, typically very anterior in a strain-related position anatomically. So you can see a common theme emerging with strain, osteoarthritis, postpartum. This is what really helps you to sort out the differences. Now, some other interesting patterns. Here, we see the entire iliac bone is lit up. And in fact, there's loss of the marrow fat signal. So there's clearly inflammation going on in that iliac bone. Again, the axial sequence tells you exactly what's going on. This was actually a 35-year-old woman, one of my patients, who I thought, well, for sure, this patient's going to have axial spondyloarthritis. But in fact, the axial sequence gave us the answer. This patient had undetectable vitamin D levels, not an unusual circumstance in Canada in the winter months. So this was, in fact, a fracture. And fractures may cause problems. Here's a typical fracture line, but it may not be as obvious as this. There's often some surrounding bone marrow edema. Chronic recurrent multifocal osteomyelitis, or SAPHO syndrome in adults. This can be very difficult to differentiate from an infiltrative process. So you can see here that there is extensive bone marrow edema in the right sacrum, and with extension of inflammation into the surrounding soft tissues. And often you really need to get a biopsy to exclude malignancy or sepsis. It's often involving only one bone. You can see there's nothing affecting, you can tell immediately there's something odd going on. And it's probably not sepsis because there's just one bone affected. So you're really, in the differential diagnosis, thinking of malignancy. And then later on in life, this patient's now 35, and you can see that there's some residual fat, metaplasia, sclerosis, so dark signal in all sequences, and some very faint residual bone marrow edema, only affecting the right sacrum. It's a very typical pattern. So sepsis typically will affect both sides of the joint. And there's two things that you typically look for. So first of all, it's often unilateral like this. There's extension of inflammation into the soft tissues under the iliacus here and the gluteus. And there's these collections of fluid which reflect abscess. So extension of bright signal on a fluid-sensitive sequence into soft tissues is a danger sign. I remember getting some images uploaded from a patient in Colombia, and I was on the phone right away trying to get a hold of the rheumatologist because it looked just like this. So this is really something that demands immediate attention. Then tumors can look very similar. You can see loss of the marrow fat signal. There's extensive inflammation, and it's going into the soft tissues. So when you see extension of fluid signal beyond the confines of the joint, that's a worrisome sign. Okay, now just some pitfalls in interpretation of structural lesions on MRI of the sacroiliac joints. So we have some definitions, ASAS-based, consensus-based definitions. Here's a typical fat lesion, homogeneous, distinct border, adjacent to subchondral bone, and associated with other lesions. You typically do not see fat lesions on their own. They're usually associated with bone marrow edema or erosive lesions or sclerosis. So a typical example of a fat lesion. An erosion defined by a disruption of the subchondral bone, as you can see on this T1 weighted sequence with the semicoronal scan adjacent to it, and loss of the adjacent marrow matrix. So this is really important, the definition. And these lesions are in fact very frequent, and the lesions co-occur with active lesions. Have a very similar proportion of patients with active lesions in patients with undiagnosed back pain presenting to the rheumatologist in the ASAS classification cohort. Now, what are some of the pitfalls in interpretation? First of all, you can see here that ASAS MRI readers actually considered fat lesions to be really quite specific for SBA with that characteristic distribution that I showed you. So paying attention to the definitions really does matter. And that might be a little bit different from what you may have read in the literature. Here's a study that looked at fat deposition in patients under the age of 45 and concluded that 50.6% had fat metaplasia. And I looked at the images, and I actually thought only this one here actually met the ASAS definition. You can see also when you look at all of these other images, and we didn't see stir images to go along with them, you should always be showing T1, stir, and the cartilage-sensitive sequence for proper interpretation. You don't see sclerosis, you don't see erosion, and that's highly unusual for an axSpA-related fat lesion. So what about age-dependent loss of specificity of erosion? You may be familiar with this work from Belgian collaborators showing that erosions increase in frequency with age. And here's some examples again. All we really see are the T1 weighted sequences. And when you actually look at healthy individuals, this is from a Danish cohort, with 3 trained readers, we see no corroboration of that data. We do not see an increase in erosions with age. When we look at the Morpho study, a Canadian-Danish collaboration in non-specific back pain patients, we do not see an increase in erosions with age. When we look at non-specific back pain patients from the ASAS classification cohort, we do not see an increase in erosions with age. So what in fact might be going on is that there may be an overinterpretation of small abnormalities, subtle abnormalities on a T1 weighted sequence. And what I think we really need to do to avoid these kinds of discrepancies is use the standardized approach that I've outlined with the 3 sequences and the axial. So I just wanted to conclude on a few final additional pearls. So things like synovitis, capsulitis, enthesitis are specific, but they only occur in about 5% of patients presenting with undiagnosed back pain. And they almost never occur in the absence of bone marrow edema. So not that helpful for diagnosis. A BME, if you talk about the extent, how much BME would I want to see? Well, it's certainly not the 2 slices that we have thought about in the past. That was an expert opinion that turned out to be wrong. You really want to see the BME in at least 3 slices and 4 sacroiliac joint quadrants, but, and this is an important but, interpretation should always be contextual. If you see additional structural lesions, that's going to enhance your confidence. But forget about the old 2-slice definition. That really is going to give you lots of false positives. With erosion in at least 2 slices and at 3 quadrants, but again, interpretation should be contextual. And finally, no structural lesions occur in isolation. If you see what you think is an erosion, there's nothing else there, it's probably not an erosion. Same thing applies to a fat lesion. There's only a fat lesion there or something that you think might be backfill, and that's all you see, you're probably wrong, and it's probably not axSpA. So there should almost always be other lesions, inflammatory or structural. So be very careful with interpreting structural lesions that occur in isolation. Okay, thank you very much for your attention.
Thank you, everybody, truly, for your attendance and giving your precious time with a very busy schedule. I wanted to thank Lisa Spiegel from Spartan and Judy Piquel from GRAPPA. I also wanted to thank AbbVie for providing the educational grants so this event became possible. Please, I encourage you to respond to the survey that you will receive shortly via email, the same email that you registered with. Thank you so much and have a wonderful evening.